Thanks for having me. I'm Dr. Anjali Vaidya. I'm professor of medicine and co-director of the Pulmonary Hypertension and CTEPH program at Temple University Hospital in Philadelphia. We are based out of our Temple Heart and Vascular Institute and a nationally accredited Center of Comprehensive Care for Pulmonary Hypertension. I've been involved in chronic thromboembolic pulmonary hypertension for many years now. We're the second biggest program in the United States, and it's really been quite a pleasure and honor to take care of patients from all around the United States who travel every day for this really complicated diagnosis to get their accurate care, accurate diagnosis, and a multidisciplinary evaluation to sort out what the best possible treatment would be.
I'm Harry Rozakis. I was PTE patient number 495 at UCSD. PTE is pulmonary thromboendarterectomy. I was a CTEPH patient who was diagnosed 32 years ago. And I went, and I'll talk about some of this stuff because it's pertinent to what I hear from more current patients. The biggest frustration for a CTEPH patient is the fact that you're constantly misdiagnosed. Now, I know the diagnosis of CTEPH has improved over the last 32 years, but there are still so many patients who go misdiagnosed. Give you an idea, in my case, the last doctor I saw before I went to Stanford recommended to my wife that I see a psychologist because that must have been the reason I was having difficulty breathing.
I hear you. Yep, I hear that kind of thing a lot, and I'm so sorry. Yeah.
If you listen to the, for example, there's a CTEPH Facebook page. If you follow those people, the stories are all so similar. All the people who suddenly they have breathing difficulties, they don't understand why. Some people are athletic, some people are not athletic. It doesn't really seem to matter what type of patient you are or what your background is. The misdiagnosis part is what drives you crazy. In my case, as I said, I went to even local. I lived in California for 40 years, and I went to local pulmonologists in California who misdiagnosed me. And then one doctor said, well, we're going to do a VQ scan on you. Well, the real story is that they did a lung scan on me and they said, oh, we're going to do a VQ scan. And then they said, don't leave the hospital. And this was a local regional hospital in California. And again, my story is very similar to what I hear from other people. And of course, it turned out that I had blood clots in my lungs. But what they basically did was give me warfarin and send me home. And that was it. And fortunately, we live 45 minutes from Stanford, and my wife, who doesn't put up with that kind of stuff, said, we're going to Stanford and we're going to find out what's really going on. And that's where I was finally diagnosed. And then from that point on, of course, at that time, this is 1994, the only hospital in the world that did PTE was UCSD, and you had to be a candidate for surgery. And in my case, I was very fortunate. I was a candidate for the surgery, and I was patient number 495. So that shows you how long ago it was. But you also forget the mortality rate for PTEs back then was 12%. It's considerably lower than that right now. And in my case, I was very lucky. I was, I recovered. I was out of the hospital in 6.5 days after my surgery. And quite honestly, I've been able to live an absolutely wonderful life for the last 30 plus years. But I've spent also that 30 years giving back to the PH community, simply because I was giving my life back. And like I said, I've had an amazing life. So it's important. But there's that whole process of being diagnosed, going through that every patient that I encounter is curious about what happens and what does it mean, and the fear before having a PTE, and what happens to the people who have distal clots and aren't candidates for PTEs. I get questions all the time. I get questions that people say, well, how long ago did you have your PT? And I go 31 years ago. And they go, you're still alive? Because they don't know how long they're going to survive after a PT. There's just a lack of comfort, and it's such a strange experience.
I'm asked all the time, sort of, what is CTEPH and how can you differentiate it from other kinds of pulmonary hypertension? This is a really important experience for the patients right out of the gate, and for the physicians and nursing and medical team facing patients that have pulmonary hypertension, to recognize CTEPH, which stands for chronic thromboembolic pulmonary hypertension, and how that's distinct from other forms of pulmonary hypertension. And so one of the most important things to think about, I always tell my patients, chronic thromboembolic pulmonary hypertension, it's too many words, it's too many syllables. Let's break it down and just recognize that we're talking about, a cardiopulmonary complication that is related to blood clots that have traveled to the lungs, which that in and of itself is a very common event medically, and anyone from children to teenagers to adults to older adults can be at risk for blood clots traveling to the lungs. And so when we're facing CTEPH, chronic thromboembolic pulmonary hypertension, we're talking about folks that have blood clots that have just not resolved, and they persist despite being on blood thinner medication, and they cause symptoms and challenges for our patients based on high blood pressure forming in those blood vessels that connect the right and left sides of the heart going through the lungs. That's the pulmonary hypertension side of it. Or just a harder work of breathing and increased effort of catching your breath. And so pulmonary hypertension, high pressure in those blood vessels that connect the left and right side of the heart, that can be caused by a whole range of other medical conditions, but CTEPH is really specific to when it's a result of blood clots that have persisted despite being on blood thinner.
One of the things I find with patients, one of the most common things is, of course, the old "why me" question. Why did this happen to me? And how did I suddenly get blood clots? One of the things that was the case back when I was diagnosed is they really weren't looking for clotting disorders. And for example, in my case, they found out 10 years later at Stanford that I had an antithrombin 3 reason for clotting. But many of the patients that I encounter ask the question, do I have a blood? They want to know, do they have a blood clotting disorder? How would they know if they had a blood clotting disorder? And of course, as you know, many of the patients don't have natural blood clotting disorders or genetic blood clotting disorders.
That's right. I'm so glad you bring this up, because it's so important for anyone who's going through a challenging medical experience to not only understand what it is and what to do, but to try to understand how they got there and what their risk may have been, and how that might have implications for their future care or maybe their family and other things medically. So you mentioned having a blood clotting disorder and your antithrombin 3, and that's really important. But it's really just a fraction of patients that have CTEPH that have it as a result of a blood clotting disorder. So you're absolutely right. We screen and test all of our patients for a range of what we call hypercoagulable states, meaning there's some abnormality that affects their ability to break up blood clots, or they're more prone to forming blood clots, and there are quite a few of those. Antiphospholipid is really one of the most common scenarios like this, and that's important to test for. But we've certainly learned as well that there are other medical conditions that may put folks at risk for developing CTEPH, even if it's not a blood clotting disorder or a hematologic, a blood disorder, as we would say. And sometimes those are other medical conditions, like having maybe a cancer diagnosis, some kind of oncology history that can make one more prone to blood clots. Sometimes it's if you've had some sort of indwelling catheter or port or line or something that's in your bloodstream that is just a mechanical nidus for clots forming on it, and those can travel. Folks that have had their spleen removed, believe it or not, are at a higher risk for forming blood clots. And we, at Temple, we've been publishing for the last, I don't, 5, 6, 7+ years on various forms of mechanical risk factors for developing CTEPH. This has been really well described now by our program and seen elsewhere for mechanical things that cause the veins to be obstructed in the pelvis. So vascular abnormalities, or women that have large uterine fibroids that can cause compression of those veins, or other compression of the blood vessels in the pelvis or in the legs that just make an individual more prone to blood clots forming in those big blood vessels that can then travel to the lungs. And so there are so many possibly associated risk conditions, and more yet for us to learn. But we are trying our very best, the whole community medically, to investigate each individual patient, what those risks might be and how we can mitigate it for the future.
And I know that what goes along with that, I think, which is so common with the patients I speak with, and certainly for myself, even 30 something years ago, is why did it take so long to be diagnosed? Why is CTEPH, even I wonder sometimes, why is CTEPH after all these years still so difficult to diagnose? And I think I understand some of the mechanics, but I'm sure you have a much clearer picture on it than I do.
Yeah, this is something we need to be better at as a whole, and we certainly are striving for education and training to make the awareness improved. But there's, a combination of things, I think, that explains why there have been delays, and that is something we need to improve. So on one hand, there's just awareness of the condition. When I was first training and a student, this was never mentioned, in medical curriculum or in training, or it was always thought to be so rare. And I think there's a correlation of it feeds into itself, this like feedback circle of, if there's a disease that's thought to be rare, and that disease doesn't have widely accessible therapies, then the medical teams that are available won't have the, if they don't have the available therapies to treat a disease, then the knowledge of that disease is limited, and the awareness to look for and think about that disease is limited, and it feeds into itself in terms of not being able to necessarily recognize it. I think, the treatments historically and to this day have relied upon the number one treatment of choice is a invasive surgery called pulmonary thromboendarterectomy, or PTE surgery. And we perform these most days of the week, but most hospitals in the world don't perform them at all. And so if you're not, in a place that has that option, it's just not on your radar necessarily to think about it, to look for it, or to even know how. And then when you combine that with the fact that chronic blood clots really can have a bit of a nuanced and subtle appearance for so many patients on the imaging of their lungs, that it's not an easy thing to recognize, but if you're not used to seeing it. The pictures on the CT scans of the lungs that find fresh blood clots, brand new blood clots, those are easy to see. Those pop out, and most people that are physicians are not going to miss seeing an acute or a brand new blood clot. But chronic blood clots don't look like that. They're more nuanced. They can be very subtle. They can be in the really small edges of the lungs, in these what we call distal kind of branch blood vessels. They line the vessel walls as opposed to floating in the middle of the blood vessels, and they can sort of hide in plain sight. And so it really can be a harder thing to recognize diagnostically from the tests. And so when you combine that with lack of available or accessible treatments, it just feeds into itself as a blind spot for patients and physicians to really know a lot about. And I'm happy to say we've made tremendous progress in that, particularly over the last decade, but we still have more work to do for education and training and awareness, so that we can shorten that delay.
Is the first step in the diagnostic process still a VQ scan? And the reason I asked the question is, fortunately, that's what they did for me years ago. But in recent years, I've actually had two family members who also had blood clots. And I told them when they were at the hospital that asked the physician to do a VQ scan. Given my background, obviously, I had some concern for them along the same lines. And again, this was a situation where they were near a local hospital. They asked the doctor about a VQ scan. He said, "No, that's old technology. We're just going to do a CAT scan." Um, so what's the process these days?
Yes, I'm really glad that you bring this up, Harry. So, when we're looking for fresh blood clots, acute pulmonary embolism, either one can be used, but the CT scan is sort of the go-to. It gives you more anatomic information. That's going to be more leaned upon. But in chronic PE, so this is a perfect segue from what we were just talking about, and I'm so glad you brought this up. In chronic PE or CTEPH, chronic thromboembolic PH, because the appearance, it can be subtle, it can be nuanced, it can be harder to recognize. The guidelines and the all of the standards of care are to do the VQ scan first, and VQ stands for V for ventilation and Q for perfusion. Believe it or not, Q flow is the sort of the physics term we're basing that on. But when we say VQ scan, we're referring to ventilation perfusion scan. And this is a totally different modality of imaging the lungs. And it's not usually the go-to way to image the lungs if you're looking for a fresh acute blood clot, which is likely why your family members or folks are hearing that feedback. But the sensitivity, meaning the likelihood that is going to pick up an abnormality, is very high in chronic thromboembolic PH and CTEPH relative to the sensitivity of a CAT scan. So a long way of saying the answer to your question is, in CTEPH, the standard of care to screen for it, to at least raise the suspicion of it, is that VQ scan. And if it is abnormal, it's not specific for CTEPH. It doesn't tell you this individual definitely has chronic blood clots in their lungs, but it does tell you that there is something abnormal with the blood flow distribution to the lungs. And maybe it's fresh blood clots, maybe it's chronic blood clots, maybe it's other things that are obstructing the blood vessels of the lungs or other disease processes, but at least it won't be normal. There's a very low likelihood that it would be normal if there is CTEPH, which is why that's the screening test of choice.
But how do we get that message out to most physicians? Because it actually surprises me a little bit, even after all these years, that there is so much misdiagnosis, that people don't do VQ scans and prepare, and of course the patients are just trying to base it on some of the patients I've talked to these days. At that point, they're in panic mode. They can't breathe. They don't know why. They're seeing a local physician who's not familiar with CTEPH, and all they're doing is saying, "I can't breathe. What do I do?"
And they've had the CAT scans maybe, and it just didn't pick up on
Right.
it. So you're right. There are things that need to be done to improve this. I'm very involved in medical education for what it's worth, and I direct our advanced pulmonary hypertension fellowship, but there are very few in the country. But not just advanced pulmonary hypertension training, even general cardiology training, general pulmonary training for the clinicians that are often faced with these scenarios. It is very much in the crux of the training programs in the current day, and has been in the recent years. So we can have hope that new physicians that are coming out, new medical students that are graduating, are absolutely learning of this, because the awareness in the last decade has really gone tremendously high. And it is on the board's exam questions, and it is sort of a classic teaching point that we are really emphasizing amongst the doctors that are learning in the modern era. I can't speak as directly to the imaging doctors. Radiologists are brilliant, and they're doing a great job in interpreting what they're seeing. And I haven't gone through that training on that side of the shop, but I know from talking to colleagues that awareness is increasing as well. But, you're reminding me of, a patient that was referred to me maybe 11 years ago by their local heart and lung doctor, saying this patient has pulmonary arterial hypertension, idiopathic, meaning we don't know where it came from, but they're being treated for pulmonary arterial hypertension for years under our care. And they're on combinations of medicines for pulmonary arterial hypertension, but it's getting worse and the medicines are complicated. And you're a pulmonary hypertension expert, so can you help us with this? So I saw the patient and went through years of records, so many years of heart caths and echocardiograms and CAT scans and a lot of PE protocol CT scans, what you were referring to, the CT scan to look for blood clots. They were all red as no blood clot, no PE. I didn't have any images directly to look at, but I have reports from other hospitals. And I said, just humor me. I don't see a VQ scan that's ever been done. I know this has been going on for 5, 8 years. Let's just get that done. And so I can be sure we're not missing anything. And in the meanwhile, let's talk about what to do with your medicines. And I got a phone call from the local physician about a week later, really kind of unhappy. Why did you order this VQ scan? He's had so many CT scans that were negative. And I was explaining, well, this is standard of care the sensitivity for chronic thromboembolic disease. And over the phone, he's like, well, it's markedly abnormal. It's really positive. And I was like, well, why are you yelling at me? But, long story short, we diagnosed that gentleman with CTEPH and he'd been misdiagnosed for years. And once we made that diagnosis, we were able to cure him. We went from being on 3 medications and him really, really failing and having severe heart failure as a result to being cured. And now it's been, a dozen years and he has a normal quality of life and no medications and is doing great. Makes a big difference, that VQ scan.
Oh, well, it helped me, but now that kind of leads to the next question that most patients have. So I just had this VQ scan and they say I have something called CTEPH. Now what happens?
Yeah, so that initial step is crucial because you have to be able to then open the door to this discussion and where we are right now in the field of CTEPH and all of the guidelines and world symposia, consensus statements, and all of our medical society guidelines tell us once there is a suspicion for CTEPH, the guidelines say you have to be referred and sort of fast tracked to an expert CTEPH center. And that's defined by doing a high volume of patient care in a year, doing more than 50 PTE surgeries or 100 balloon pulmonary angioplasties and having a multidisciplinary team and great outcomes and all of that. And the reason that that's important is because the treatment options are complicated and they have to be really individualized for what the patient is a candidate for. Right. So the choices include, I mentioned before, a surgery called pulmonary thromboendarterectomy, or some folks call it PEA, pulmonary endarterectomy. That's the standard of care if it's an option for the patient based on their medical condition and their anatomy of their disease, because that has the potential for cure. In addition to that, either instead of or maybe after, there may be an option for something called balloon pulmonary angioplasty, or BPA. This is where it's not open heart surgery through the chest, but it's through catheters that we would insert into the veins initially, travel to the heart and get into the arteries of the lungs and open really tiny balloons into multiple vessels to try to open vessels that have been narrowed by chronic blood clots. But that's usually reserved for smaller branches of the blood vessels in the lungs, not the more major large ones in the center of the lungs that might be blocked by clots. And then if a patient is not a candidate for surgery and they're being considered for balloon pulmonary angioplasty, or if it's after they've had surgery, but there's still some residual pulmonary hypertension, then there's one medication that's been approved to be used in those scenarios. And that's been a huge innovation over the last 11 or so years now, but only if they're not a candidate for surgery or if they have residual disease after their surgery. And it's being used often as well, like I said, in conjunction with that balloon pulmonary angioplasty procedure, or BPA. So if this sounds complicated. It's because it is. It's because any individual, any one of us, if given the choice, would say, I'd rather not have a major surgery. Medicine sounds a lot easier. Why don't I do that? Or I'd rather have a catheter-based procedure with balloons, even though that's invasive, but that seems less risky than an open surgery, on my heart and lungs. And so that the natural inclination is to sort of wish it was a menu of options that you could kind of choose from. But in reality, every individual's disease, their CTEPH, their individual chronic thromboembolic pulmonary hypertension will guide what treatment option is the safest, the smartest, and likely to be the most effective for that patient to derive the greatest benefit. For example, you may have somebody whose disease is so obviously a surgical candidate for PTE. That type of patient usually would not benefit from medication or balloon pulmonary angioplasty. And vice versa. There may be a patient who, the rare patient who's not amenable to a PTE surgery at all. But, they may respond to medication, but you may be tempted to say, well, surgery is the gold standard. Let's do that. And you may take on a risk for a patient who's not likely to derive benefit. So the initial thing, you ask the question, after the diagnosis, now what? It's an immediate referral to a major expert CTEPH center. And, for example, we refer these cases, we review cases from all over the country and review them in our multidisciplinary team that involves, our cardiology experts on CTEPH, our surgical experts for the PTE surgery, interventional cardiology for balloon pulmonary angioplasty, radiology, all of our experts in the room, and on an individual basis will guide that treatment.
One of the questions is, and it's kind of one step before what we just talked about, is when the patient is diagnosed after having a VQ scan. And again, these are all part of the patient fears that I hear as a fellow patient, is they hear, okay, I've had this VQ scan. Now the medical center that I've gone to wants me to have either, back in my day, it was a pulmonary angiogram or right heart catheterization. Most people don't know what that is. So the first question is, what is that? What are they going to do to me? What happens to me? And so maybe you could address that point a little bit.
Yes, absolutely. So that's really important. The testing that goes into the diagnosis, I wish it was so simple as you have a symptom, you have a VQ scan, and now we figure out if you're, what the treatment is. There's many, it's like many pieces to a pie or pieces to a puzzle, and you kind of need every piece together to come up with that full assessment for each individual. And a really important part that you're referring to is the part that happens in our cath lab, in our cardiac catheterization lab, where our interventional team will put catheter into the right side of the heart, and it will go through the chambers and circle around into the pulmonary artery and measure the pressures and flows really in the heart and lungs. That's called a right heart catheterization. And that's the gold standard to diagnose any form of pulmonary hypertension, to really get those numbers. How high are the pressures in the lungs? What's the stiffness of the arteries of the lungs? How much pressure and strain is that putting on the right side of the heart? Is the heart able to generate enough flow every heartbeat and every minute? Is the right side of the heart too strained to be able to compensate? You learn a lot about an individual's physiology from the right heart catheterization.
And what do the pressures mean though? Because what patients will ask is, they'll say, and I'm sure even back in the day, I had the experience that most patients have, which is you're being told all this information, but you're in another planet. You've been told something that is you're not even prepared for, and you're just constantly given information that you don't know how to react to. One of the things is, what people always say, what are your pressures? Well, what does that mean for the patient? And then what's good, what's bad? Because a lot of patients don't know.
Yeah, so, a normal mean pulmonary pressure in the lungs would be quite low, less than 20 or 25, depending, the definitions have ranged over the years. But that's just one part of what's being looked at. So that's the pressure number. But there's something called pulmonary vascular resistance, which is a calculation that's made based on the pressures in the lungs, the pressure on the left side of the heart, the flow that's going through there. And so we call that PVR, pulmonary vascular resistance, and that's very specific to how stiff the lungs are, the blood vessels in the lungs are. And that number should be less than 2 or 3 Wood units, we say, or 240 dynes. There's different units and different number cutoffs to consider this, but conceptually, the initial thing is how high is the pressure and how, what's the stiffness of those arteries in the lungs? And then secondary to that is, okay, what's the heart's ability to sort of compensate? Because when people are sick from pulmonary hypertension of any kind, including thromboembolic pulmonary hypertension, CTEPH, it's the effect on the right side of the heart for the most part that's causing the symptoms, the limitations, the, struggles and how far you can walk and your breathing when you're going up the stairs and sort of that risk over time. It's a form of right-sided heart failure. And so we're looking at not just the pressures and the numbers in the blood vessels of the lungs, but the numbers that represent the effect on the right side of the heart also. But also in that procedure, you asked about not just the heart cath, but the pulmonary angiogram.
Mhm.
And that's something that it's sort of another layer to what's done during that procedure. So a right heart catheterization can and should be able to be done at most hospitals that have a cardiology program. The pulmonary angiogram part of things, I will say, we typically reserve to do that at our program as an expert CTEPH center, because the technique of doing it specifically for the diagnosis of CTEPH takes a lot of skill. Pulmonary angiograms have been performed for many, many years, often usually to look for the really big, what we call massive or submassive, acute, brand new, fresh blood clot that might make a patient really sick, and they end up in the cath lab to have, this diagnostic procedure. But the technique in that scenario is different than what we need for CTEPH. We need really high quality images that will give us good clarity in all of the branches of the blood vessels, all the way out to the edges of the lungs. It's another way of providing that anatomic roadmap, so to speak, to really understand an individual patient's clot burden. How much is it? Where is it? How many blood vessels? What distribution of blood vessels? So the pulmonary angiogram, the right heart catheterization, in addition to the VQ scan, the CT scan, the echocardiogram, the ultrasound of the patient's heart, the patient's medical history, examining them, talking to them, all of those things together are used by the expert CTEPH center to then guide what the best treatment would be.
And so the thing I hear after this is, of course, now you've been diagnosed, and then there's the 2 paths you can go down. One patient is told you're an ideal candidate for surgery, and they're going to want to know all the prep that's necessary for surgery and what they can expect during surgery. But then there's the other patient who's told, well, I'm sorry, your clots are distal and we can't reach them. And so they're left asking, well, then what happens now? So maybe we could look at those 2 paths.
That's really important. So let's take this scenario, because we focused a lot about surgery. Let's just say a patient is told they're not a candidate for surgery, or that it's not an option. We'll start with that option, with that path. And interestingly, all of the guidelines will say, are you sure? Literally, make sure that patient is evaluated by a high volume expert CTEPH center to confirm that before they're assumed not to be a candidate. So that's an important piece. But let's say that's been done and they're not a candidate to go down that road for surgery. Then thankfully there is an approved on-label FDA approved medication to at least treat the pulmonary hypertension component, meaning the high pressure in the lungs, to try to take some of that load off the heart, some of that pressure down, some of the resistance down. That medication is called Riociguat, or the brand name is called Adempas. And that's been available, was initially published over a decade ago in the New England Journal of Medicine. It was a really landmark, important trial that really changed the field so much to give this medical option for these patients. So that can absolutely be used. It's not meant to be used instead of surgery or to delay surgery, but it can be impactful for those, as you nicely described, who have that distal disease at the edges of their lungs that may not be a candidate for surgery.
And then when we talk about having a PTE,
Mhm.
um, the biggest fear, of course, for a patient going in is the unknown. I'm not sure. I think PTE surgeries are now about 6.5 hours or something like that. I think they were 11 back when I had mine. But uh, the other question I always get from patients is, well, what can I expect? What's going to happen? And some like to be more graphic than others, for sure.
True.
Some don't want to know anything, but maybe we can talk a little
Understandable.
bit about that.
Absolutely, understandably, um, it's a big surgery. There's no reason, it doesn't help anyone to kind of sugarcoat or candy coat that. It's such a complicated, big surgery that there are very few hospitals in the country and the world really that do it at all. And so that's humbling and that's important to note. If it were simple, everyone would do it. The surgery itself it's open chest surgery, sternotomy through the center of the chest, all under general anesthesia. Um, and it involves going into the main pulmonary artery that comes off of the right side of the heart, which is right behind sort of the sternum, the breastbone, and opening that up and taking a really close and careful look throughout the pulmonary artery branches on both lungs, the right lung and the left lung. But everyone's anatomy, pulmonary artery anatomy, it's sort of like those branches of a big oak tree or a walnut tree where there's a really big trunk and then there's really big branches and then there's medium-sized branches and then there's small branches and then there's little twigs and you can't even count them all. There's so many branches off of the main vessels, and those small branches go out all the way to the edges of the lungs. And in order for the surgical team to be able to perform the surgery, the patients are, of course, asleep under general anesthesia. There's something called deep hypothermia and circulatory arrest, meaning we have to cool down the patient's body temperature significantly low and stop their circulation for periods of time in order for the surgeon to be able to do that really complicated removal of the blood clots. Remember, these blood clots are not free floating. You don't just pick them out of the lungs. They're chronic, meaning they're sort of adherent and stuck to the lining of the blood vessels. So it's a real effort to carefully, meticulously, dissect that plane and be able to peel away the chronic blood clots. And it's the most advanced form of anatomical plumbing you could sort of imagine from a medical perspective. And so the surgery itself, as you said, it takes several hours. The patients come out of the operating room on the ventilator in the ICU. That's standard. And they'll, in our program at Temple, they're in the ICU overnight until the next day on the ventilator. And then we work in that, post-operative day, 1 or 2, usually 1, we get them off the ventilator, and then we try to get them up and moving and walking around quickly and out of the ICU within a couple of days, and ideally up, healing up on the regular floor of the hospital and out of the hospital at our program less than a week most often, but it's variable for each patient and it's variable for each program and center. You may hear stories of people in the ICU for longer or in the hospital for longer. And I always say, the healing continues for weeks and months after being out of the hospital. It's a big surgery to go through multiple layers of anatomy and that are being affected. And so the healing and getting your strength back, it takes time over weeks to months. And but that's the general experience. So we have patients, like I said, that come from all over the United States, and we tell them to be prepared that they may be in the hospital on average, 5 to 7 days, maybe a little bit longer. But then we at Temple, we follow all of our patients after their surgery in the office for post-operative checks within a week or so after they are discharged. And then even in the months and years to come after that, we don't want to lose sight of how patients are doing. And I mentioned the medication option, that may be something people might benefit from down the line, or the balloon pulmonary angioplasty in combination. And we want to guide people's local doctors who may not do this as much on the best way to use medications. You know, there are other medications for pulmonary hypertension, but none other are approved to treat CTEPH. And so we always want to be a guide for people's doctors on not using off-label medications that might have more side effects or more adverse effects if that's not appropriate for this specific diagnosis. And so that the complexity of how we think about it continues even after surgery to make sure we're doing right, you know, before the patient's treatment, after, and forever after.
Well, boy, you said a lot there that I personally would like to address.
Yes,
But-
I would love to hear your story and your
Well,
experience. Yes.
So I think one of the things, of course, back when I had my PTE, UCSD was the only facility in the world, and I was living in California. So it was logical that Stanford, who diagnosed me, sent me down to UCSD to have my surgery. One of the post-op things that I can highlight for people is the prep that I was given about waking up in the ICU was excellent, because I know some patients panic when they wake up in the ICU. You know, like you said, you've got every kind of tube in the world stuck in you, and you're disoriented. But to their credit, they really prepared me. And when I came out in the ICU, I said, okay, I know where I am, and I'm glad I'm alive. That was the typical reaction probably of most patients. The thing that interests me a lot, and a lot of patients ask me about, is long-term post-op. And I tried for actually quite a long time to get people on board with me on this, but it's been very difficult. So I'm probably spouting something that I'm an advocate for, but it's long-term. What can the patient expect over the long term? And what I've always felt is I wish there was a way that a study could be done to look at patients one year post-op, 5 years post-op, 10 years post-op, and even out as far as me, 30 years post-op. And what happens during that period of time? And does anything occur during that period of time that can relate back to your CTEPH or to the medical procedure you had? And I know a lot of patients treat things a little bit different. Obviously, I've been an advocate for this for a long time. So one of the things that I tell patients is, you have been given a gift. You've been given a new life, and you should take that body that you've been given back and take care of it and do what you need to do to take care of it. You know, I'm now 74 years old. And it's like, I've made sure that I've taken care of that gift. And then I always tell them the other thing they need to do is find ways of giving back. But that's my pitch for donating and taking care of it. But I know that there is a concern about the patient's community. I made a joke in the beginning of this conversation about people always saying to me, you're 31 years post-op and you're still alive. But that question is out there. A lot of these people have no idea that they can go on and live a fully normal life. I mean, I've been very fortunate. I've had a great life. I've lived all over the world. I've done some amazing things. It's all post-op. So I think those words of encouragement actually coming from the medical side would be really important.
Yes, thank you for sharing that, and I just really admire and commend your story, your strength getting through it, navigating it at a time where there weren't, you know, awareness and resources like we have now, and even though we still have more to do. But you're right. I love hearing you say that. You know, one of the greatest joys for me as a physician is celebrating the restoration of life and quality of life, you know, in my CTEPH patients after their PTE surgery, or even, you know, our patients, we do so many balloon pulmonary angioplasties. We're having amazing results that are just life-changing. And so, you know, I have weeks where I see patients, so many patients in a week that we operated on them or did their BPAs, or, you know, all in conjunction with medicines years and years ago. And they're, you know, they're just having the best lives, growing their families, traveling the world, having normal quality of life. And that is why we do this. And that is a common scenario when done under, you know, an expert program with CTEPH expertise. That is the goal. And, you know, the important part about that, you know, we're not just seeing our patients so we can celebrate with them, even though the human in us would love to just be able to do that. We're watching them closely because there may be a scenario where if a patient maybe wasn't able to stay on their blood thinners for whatever reason, because that is something that does have to stay, you know, long term to try to prevent and lower risk of more blood clots forming. So there may be scenarios where somebody might have a new blood clot that formed years down the line, or you know, recurrent CTEPH. It can occur. It's the minority of patients. We feel strongly at Temple that we follow all of our patients long term. You mentioned, you know, I wish there were data on how patients were doing a year or 5 years, or, you know, we have that. We follow that in our patients. They come back and we collect what we can so we can learn that, so we can, you know, offer anything more that they may benefit from down the line. I often will say to my patients, you know, there's a starting point and a finish line, and you're starting here and we want to get you to the finish line. And the treatment we offer you now may get you all the way there, and that's great. But it may get you here, and that's really, really, really good compared to where you were. But it may turn out in the months or years to come after that we can still get you for more benefit, whether with medication or with balloon pulmonary angioplasty or whatever it may be. So, you know, one of the biggest black box, so to speak, or kind of blind spot for the medical side of CTEPH is how to recognize pulmonary hypertension after a PTE surgery, and what to do about it, and what do you respond to. And so, you know, we talk about this a lot. We've written and published on this out of our program at Temple, kind of clinical guides for physicians to really do an integrated, comprehensive clinical assessment even after the treatment, so that we're not letting anything fall through the cracks. But for the most part, it's a very rewarding, very positive, hopeful outcome with wonderful, you know, long-term prognosis when done in high volume expert experience centers. Just like other complicated medical things like transplants, you know, the outcomes are always the best when they're done at places that do it the most.
Right, right. But I think definitely the long-term prognosis is so important to people. I'll share this with you. I don't know if it's they can probably edit this out if they want, but just as an example. So I did have my PTE 31 years ago, and made sure I stayed in great health. I was within 6 months of my PTE, I was running 6 miles a day and back to doing all that kind of stuff. But at age 64, 10 years ago, I developed AFib, very mild AFib, but I developed AFib.
Yeah.
And I moved to North Carolina at that time. So I see an electrophysiologist cardiologist at Duke. And what's interestingly enough is he was at UCSD when I had my PTE. And what he told me, and I don't know how true this is, but he told me the way they did the surgery 30 years ago was a little bit different than they do it now. And they disconnected or cut the pulmonary arteries too close to the heart back then. You do develop scar tissue. And he felt that the AFib that I have now, which is totally under control, so I don't worry about it, but was a direct result of the scar tissue that formed as a result of surgery. You know, but these are things like people, I don't meet too many long-term post-op patients, but when I do, we talk about those kind of things, and that's what people are interested in.
Yeah. Oh, go ahead.
So one of the concerns that are out there amongst patients is the availability and usage of off-label medications, and maybe that's something you can comment on.
Absolutely. You know, the field has evolved a lot, and just like any other part of medicine, you know, we're learning, and there's an era where there are treatments that are available, and there are eras before that when there weren't. And so it's a very natural question that, you know, are there more medications that can be used? And especially for patients that are talking to other patients who have lived with pulmonary hypertension. And maybe it's not chronic thromboembolic pulmonary hypertension, but it's other forms of pulmonary hypertension, because this is a close-knit community and patients meet each other and they talk to each other. There are a lot of patients with pulmonary arterial hypertension, which is a different form of pulmonary hypertension, that are on 2, 3, or 4 medications to treat that. And that's a distinction from CTEPH. The other medications that are out there to treat pulmonary arterial hypertension are not on label to use for CTEPH. And so there are some downsides, certainly, to use additional off-label medications for CTEPH. One of the most common is simply the fact that, you know, it's very tempting for patients and physicians to want to use medications before doing invasive things and procedures and surgeries. And we see that happen a lot, where patients may be treated with multiple medications, but it delays the treatment that's really effective. It delays the treatment has the potential for cure. It delays referring to an expert center to get them the disease-specific CTEPH treatment. And that can be really harmful. And the side effects often are more exaggerated when you're using medications for the wrong indication. The benefit for that medication then becomes less, but the side effect profile can be more exaggerated. And so it can be harmful and really difficult for patients to tolerate multiple medications when they're not indicated for this diagnosis. In general, our medications for pulmonary arterial hypertension are complicated. You know, these are not over-the-counter simple medications. They're complicated. They have a lot of potential side effects and interactions. And when they're used correctly for the right disease, then the benefits outweigh the risks and the downsides. But otherwise, it can really cause more trouble than benefit if that's done.
Is there variability in both off-label and generic versus brand?
Yeah, and so it's a really practical question, and a real, I mean, we hear stories like this a lot across medications. And so for the on-label medication, we don't have that issue. But for off-label medications, some of them do have generic options, not all of them, but some of them do. And certainly, you know, in theory, you would think there is no variability, but certainly there is that potential of variability that can happen both with the molecule that's dispensed and also sort of the support, patient support that goes along with it. So yeah, it does add to complexity of what the patient might experience.
My pleasure. I really appreciate the time.
Me too. And Harry, it's so good to meet you and to hear your story. And it's really inspiring. And I'm, you know, the fact that you said about giving back to the community and the patient support, I really admire that a lot. And thank you for doing that. It's really tremendous.
Thanks. Just tell I tell patients online all the time, just post-op, just go to the gym. Even if you never went to the gym, go and do baby steps on the treadmill. Baby
Yes,
steps.
you can now. Yep, I love it.
Excellent.
Perfect. Thanks
So
so
much.
much.